In the last few years, a lot of new information has become available on how large the disease burden is, especially in low and middle income countries. As you know, a few years back, there were a handful of studies that tried to look at deaths, how many deaths occurred. And we found that the hundreds of thousands of deaths every year in the world, really the vast majority of the deaths occur in low and low middle income countries. And that's especially true of children, where almost all the deaths, more than 99% by some estimates, occur in the lowest income countries. And while there isn't enough data on the economic impact in those countries, it's probably huge. And we saw a recent paper from the Laos Ministry of Health, which tried to estimate the impact and the cost effectiveness of vaccine in their country, and found that, in fact, vaccine was cost savings in Laos, not just cost effective, so that for every dollar spent on the vaccine program in Laos, you actually had more than $1 in economic gains. And so this is hugely important because it shows that influenza vaccines are not only a tool for reducing pneumonia and deaths, especially in low middle income countries where the risks are the highest, but also potentially an engine for economic development. We talked to vaccine program managers about what they think of the challenges for growing influenza vaccination programs. And we found a few key barriers. The first one, there was a real underappreciation of the disease burden and the economic burden of influenza in their countries. And therefore, the value of influenza prevention was also underappreciated and undercommunicated. So as a result, there was very little priority given to influenza vaccine in their country because the data just weren't there. The second thing they talked about was access to vaccine. That was often a barrier too, because there were too few vaccines approved in their countries, and therefore not many options of vaccines, and therefore the vaccines were often relatively high cost as well. And finally, funding was a problem. Some mentioned that some external funding to get their program started as a catalyst for program start were needed, and even some vaccine doses, so that they could develop develop experience with vaccination programs, therefore to create the evidence base and make it an easier argument for national funding for vaccine. I think there's a bunch, but maybe we focus on a few. First and foremost, better communication, better education, especially of health workers. And health workers are critical because health workers are the people who recommend vaccine. And in every study done, whether you're in a low-income country or a high-income country, people listen to health workers. They listen to their recommendations. So if health workers don't know about influenza, don't know about the value of influenza vaccines, they won't recommend them. So first, better education of health workers, providing them the tools for communicating to their patients about the value of influenza vaccine. The second is, despite the need to say what we know better and educate people with what we do know, we have to know more. And so we do need more data on disease burden, we need more data on the economic burden, and we need more data on the value of influenza vaccination, both in terms of disease reduction and in costs, especially in low-income countries. We also need better tools for country managers to both communicate the value of vaccine, but also to estimate how many vaccines they need, to estimate the demand so they can order effectively and efficiently. And finally, I think, and really importantly, we need more vaccines in these settings. More vaccines means reduced costs, means better options, and also means better uptake of these vaccines. So just more products available in these countries. And finally, I'll go back to something I said earlier, and that is that countries often need technical support and early funding, especially early in their programs, in effect to de-risk the early programs to give them time to gain experience and gain a value for influenza vaccination. This is a really important point because we know that the same skills, the same capabilities you develop during a seasonal influenza vaccination program provide an effective foundation for pandemic vaccine responses. We saw that in 2009 H1 pandemic, we saw that, and we're seeing that now in the COVID-19 response, where countries that have influenza vaccination programs that target the same groups that get influenza vaccines do a better job of responding with vaccine. They do it faster, they do it more efficiently. And so the capabilities that you grow, that you develop during influenza vaccination campaigns are exactly the same capabilities you need for pandemic responses. You train your health workers to give vaccines and to recommend vaccines. You do program planning. You find out where your vulnerable people are. Where do the diabetics live? How many live here? How many live there? So you know where to distribute the vaccine. You develop your safety monitoring capabilities such that if there's a safety signal for a pandemic vaccine, you know it quickly and you respond to it appropriately. You develop your regulatory laboratory expertise in licensing vaccines quickly, and you develop your expertise in evaluating and refining your program quickly over time. The other things that you do is you target adults, the same people that get pandemic vaccines. And because influenza vaccination programs happen every year, you actually practice these skills every single year so that when the pandemic occurs, you're ready to go. And so it's really the argument for influenza vaccine, the evidence for it, is not only based on the fact that influenza vaccine is a mechanism to reduce pneumonia cases every year, but it also, the argument should include the ability for countries to use influenza vaccination programs targeting health workers, targeting pregnant women, to build those same capabilities that they can mobilize very quickly when it's most needed during a pandemic. We know that influenza programs serve as a critical foundation for overall preparedness. And as I said, they provide expertise, they provide capabilities to respond not only to influenza, but to other pathogens. But building these sustainable programs is a process. It takes time, from making the case for investment to countries, to building demand, to building capacity to do this. So Ready to Respond actually works to generate critical data for countries where those data are needed most, and also to develop practical solutions or tools that are needed by countries and can be easily used by the countries. And so the first focus areas of Ready to Respond, both in terms of data creation and tool development, are on burden of disease and economic disease, the economic case for influenza readiness. So can we create more data at local levels that allow local decision makers to understand the value of prevention? So that's the first area of focus. The second area is to support the growth of influenza and COVID-19 vaccine programs as a vehicle for pandemic preparedness for the same reasons we just discussed. So Ready to Respond has recognized that the solution to influenza prevention globally and to make progress requires all partners, both public and private, to work together in partnership. We can't just do it alone on the public side or the private side. We need everybody to working together towards consensus goals, doing consensus activities, and talking with each other. And we think that by working in this partnership way, we believe we can really have a huge impact at readiness and also annual disease reduction.